بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم أجمعين. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك أنت العليم الحكيم. My topic today is about approach to adrenal mass. My objectives to become familiar with the different imaging techniques of adrenal gland, to give examples of different imaging appearances of adrenal masses, how to differentiate between benign and malignant adrenal lesions by different imaging techniques, to understand the impact given that the patient has or has not malignancy. Incidental adrenal lesion, also known as Incidental, adrenal mass discovered incidentally when investigating for something else, no clinical syndrome associated or presence of metastatic disease. Adrenal masses are seen in about 1 to 5% of CT examination. Most of these masses are benign, even in patients with a non-malignancy. These masses are usually non-functioning adenoma, and the issue is how to differentiate these benign adenomas from malignant adrenal masses. Adrenal masses, benign versus malignant. The most common tumor in the adrenal gland is adrenal adenoma. Adenoma are reported to occur in from 1.4% to 8.7% of post-mortem examination. Adenomas large enough to be recognized at the abdominal CT scan examination are found in about 1% of patients. A question to be answered about the adrenal incidental lesion: is it hormonally active? Is it benign or malignant? What are the differential diagnoses of adrenal incidental lesion? Adenoma, hyperplasia, carcinoma, pheochromocytoma, myelolipoma, hematoma, cyst, adrenal metastasis, ganglioneuroma, neurofibroma, hamartoma, infiltrative lesion. In patients with cancer, up to 50% of adrenal lesions are metastatic. How to approach? Look for prior CT or MRI. If there is no change, it is benign lesion adenoma. If it is increased in size, metastasis most likely. Breast cancer with mass lesion, as in this example, is it benign or malignant? Because it means different staging and it will impact on treatment. As we see here, right adrenal mass with enhancing. Also here, this patient with lung cancer with mass lesion on the right adrenal gland, is it benign or malignant? If it is malignant, will give different staging. It will impact on treatment. Morphological feature of incidental adrenal lesion depend on size, shape, heterogeneity, are usually not helpful in 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 determining if it is benign or malignant. We need better tests to avoid biopsy. How to characterize the lesions? Adrenal adenoma have two properties that differentiate them from non-adenoma. 70% of adenoma contain high intracellular fat, lipid-rich adenoma, and will be low attenuation on an enhanced CT scan. Adenoma rapidly wash out contrast. CT scan the primary imaging the tool. Slice thickness 2 to 2.5 millimeter. Non-contrast scan first performed, contrast study then performed. Arterial phase or parenchymal between 25 to 40 seconds. Venous phase about 70 seconds and delayed phase after 15 minutes. Unenhanced CT scan using a safe threshold value of 10 Hounsfield unit on a native CT scan result in a sensitivity of about 70% and high specificity of 98% for diagnosis of adenoma. A density equal to or below 10 is considered diagnostic of adenoma. 30% of adenoma don't contain enough intracellular lipid to have a density less than 10 and cannot be differentiated from malignant masses on an enhanced CT scan. These are adenoma called lipid-poor adenoma. Here we have a left adrenal mass on this patient and on another patient. And we should know how to put the cursor of region of interest of these masses and should include at least half of the lesion. Here this patient with right adrenal mass, with patient with cancer, breast, it is benign or malignant. We see the non-contrast CT scan and the density of the mass, it is about 4 Hounsfield unit. So this is straightforward for adrenal adenoma, and this is benign and no further treatment is advised. Here, this is a patient with lung cancer, and the density of the mass is minus 19 on non-enhanced CT scan. And this is also the density of the mass, it is about 22 HU on enhanced CT scan. And this is also an adenoma. MRI, it is correct localization and size. Morphology, single most important imaging. A protocol is chemical shift imaging, in phase and out phase sequence. Other sequences also might be helpful. Here, this patient has right adrenal mass And this is the in phase, and this is the out phase, and the out phase, the mass become more low attenuated than the in phase. It is consistent with adrenal adenoma. Chemical shift MRI, signal intensity decrease on opposed phase image 25%. Signal intensity index is less than 20, and adrenal to spleen ratio is about 0.7. Intracytoplasmic lipid limitation: up to 30% of adenoma remain indeterminate lipid poor. So we need more accurate tests to determine whether this mass is benign or malignant. Here, this patient with seminoma with adrenal mass, and the density of the mass on the non-contrast CT scan is about 31 HU. It is benign, it is malignant. What is the staging and what is the treatment? We do the delayed CT contrast enhancement, the delay after 20, 30, 15 minutes. If it is less than 24 HU, it is sensitivity, it is about 96, and the specificity, it is about 96. If it is 30 minutes, it is the specificity about 100%. And after 1 hour, if it is 100%, and the Hounsfield unit is less than 30. Limitation with absolute attenuation value. Misinterpretation in case of borderline enhancement. Different types of CT scanners. Different types of amount of contrast material and different delivery rates. Contrast washout. We have absolute washout. It is an enhanced CT scan minus delayed CT scan HU over enhanced CT scan minus unenhanced CT scan multiply by 100%. And the absolute washout should be more than 60. If it is more than 60%, it is benign adenoma. If it is less than the relative washout, if it is more than 40, it is a benign adenoma. CT algorithm, benign versus malignant. Mostly an adrenal mass will be found on an unenhanced CT scan. That is performed in patients with abdominal complaint or patients that are referred for lung cancer staging or other tumor staging, as differentiation between benign and malignant is usually not possible on initial enhanced CT scan at 60 seconds. So ordering the patient back for a dedicated adrenal CT is best strategy, although some prefer MRI. If on the unenhanced CT the density is equal to or below 10 Hounsfield unit, the lesion is considered to be an adenoma and no further workup is necessary. If the density is more than 10 Hounsfield unit, the washout should be calculated. If the washout is not compatible with adenoma, a biopsy can be performed if definite diagnosis is crucial to the patient management. Algorithm for differentiating adenoma from non-adenoma. We have adrenal mass. If it is less than 10 Hounsfield unit on an unenhanced CT scan, it is adenoma, lipid-rich adenoma. If it is more than 10 Hounsfield unit and washout, it is more than 60%, it is lipid-poor adenoma. And the washout, if it is less than 60%, it is undetermined lesion. Here, unenhanced CT scan, the left adrenal mass with a density measuring 9 Hounsfield unit, and so this is adenoma. And in enhanced CT scan at 60 seconds, it is 43 HU, and on the 15 minutes, if it is 22. The absolute washout, it is 61%, so this is adenoma. And the relative washout, it is 48%. It is also consistent with adenoma. There is adenoma on the right side here, and with low density, but there is also metastasis, and it is enhancing mass with low density area, low attenuation due to necrosis, consistent with metastasis. Here, this is a mass lesion on the right adrenal gland with average density about 31. And after enhancement with average density, it is about 57. And the absolute adrenal washout, it is 30%, so this is not benign. And so this is not benign lesion. And absolute relative washout, it is 14%, so this is not benign lesion. With CT scan, how useful? Combines complementary modalities, allowing a precise structural and functional characterization of adrenal lesion. FDG, but highly sensitive and specific for differential diagnosis of malignant form benign adrenal diseases. Accuracy not influenced by the type of imaging device, bit versus bit CT scan. No significant differences in accuracy among the visual standard uptake value and standard uptake ratio analysis. General rule: if we have right adrenal mass lesion on the right side and the bit is the uptake is less than the liver, so generally it is likely a benign lesion. Here we have two mass lesions, one on the right side and one on the left side. If the tracer uptake almost equal to the liver, most likely or probably it is a benign lesion. If the tracer uptake on the adrenal mass is more than the liver, it is an indeterminate lesion. And if it is more than the liver, it is malignant lesion. So we have limitation on PET CT scan. Lesion is less than 1 centimeter. It is the resolution. It is not good. Hemorrhagic versus necrosis. Non-functional FDG, avid malignant lesion, primary or metastasis, bronchoalveolar carcinoma, renal cell carcinoma, or carcinoid. Some avid increase tracer uptake in adrenal and hyperplasia, pheochromocytoma, infection, and surgery, and brown fat. Diffusion, if it is useful imaging, utility of diffusion-weighted imaging is characterization in adrenal mass, differentiation between benign and malignant adrenal mass, and differentiation lipid pool from lipid-rich adrenal lesion. And it is not useful diffusion for adrenal cyst. ADC of adrenal cyst differ significantly from the other lesion. Wide range of ADC in adrenal adenoma, no significant difference between adenoma and malignant lesion, and no significant difference between metastasis and adrenal carcinoma. No significant difference between malignant lesion and pheo and neuroblastoma. No significant difference between lipid poor and lipid-rich adenoma. No correlation between percentage signal intensity decrease and ADC values. ADC is not useful in differential diagnosis between benign and malignant adrenal mass lesion. Diffusion not useful in differentiation between lipid poor and lipid-rich adenoma. In conclusion, no unique test for differentiation, no non-contrast CT scan effective for adenoma, CT washout for with CT dedicated protocol for lipid-poor adenoma can stop there. Will be some indeterminate lesion, PET CT increase the or used with this patient. Few adrenal lesion with need biopsy. Thank you for listening. Hoping to see you in another talk.